Pediatric orthopedics, a chapter that people leave they should not. It is difficult, but if some basic concepts are acquired, it's highly scoring. Shape of the femoral head and its congruency into the acetabulum means matching shapes allow for two specialized movements at the hip joint: abduction, internal rotation. Same as with the shoulder. Ball and socket joints, if they are normal, these two movements are normal. When we flex the hip, the knee will go towards the center of the clavicle. That is called as a normal axis, goes to the clavicle. Normal to C, clavicle. If the shape is altered on flexion, the knee goes to the axilla, called as axis deviation. Hip joints, the investigation of choices are usually MRI and treatment. In a child, maintain the hip. Get the head inside the acetabulum. If you maintain the head inside the acetabulum, over time they attain a normal shape. These are the movements. When you take your leg out, your thigh goes in. This is internal rotation. If this movement is there, it means that the hip is normal. When you take the leg in, thigh goes out. External rotation. Not significant. This is significant. If I look at the diseases around the hip joint, you see DDH right at the birth. 20% bilateral. Perthes, age group 4 to 8 years. 20% bilateral, very commonly asked. Slipped capital femoral epiphysis, 11 to 20 years. So there are 3 diseases in second decade of life: osteosarcoma, osteochondritis dissecans, and slipped capital femoral epiphysis. When I look at male is to female ratio, slipped capital femoral epiphysis more common in males, Perthes more common in males. You add them, go in the reverse order down to up. 1:6 for DDH, more common in females. When we look at developmental dysplasia of hip, the disease is the head, the femoral head is in the flat acetabulum, shallow. And the femoral head is also small. So they have small epiphysis, shallow head, acetabulum. So it becomes unstable, goes up. The pubic rami and the upper and femur, they make an arch. Here, the Shenton's arch is broken. Small femoral epiphysis as compared to normal side. Shallow acetabulum as compared to deeper socket on the normal side. The femoral artery pulsations are felt against the head of femur. Here, the head is not there. The femoral artery pulsation is not felt, called as vascular sign of Narad, positive, and the head goes up, called as superolateral dislocation. The classical test, ortolani, means when you abduct, the head comes in the acetabulum, it gets reduced. Reduction on abduction. O rub. Ortolani, hip ko andar lana, means reduction of the hip. Thigh goes out, but the head goes in. As compared to it, Barlow's, you adduct the thighs, the head goes out. Baharlo, dislocation. Ortolani, test of reduction. O rub. O rub. O Almighty. O rub. We pray like this and we say reduction on abduction. Baharlo, Barlow's, adduction, dislocation or adduction. That is bad. If you ask the patient to lie supine, their knee should be at the same level. The side which is dislocated, the knee will be at lower level, called as Ali's or Galeazzi test. For bilateral DDH, we have a Kleisig test. These are the clinical tests. When I draw lines on the x-rays, if I draw a line from the edge of the acetabulum, draw a vertical line, it's called the vertical line of Perkins. And when I draw a horizontal line from the center of the acetabulum, it's called as the horizontal line of Helgen-Renners. They make quadrants, and when they make a quadrant, down and in is a normal femoral epiphysis, and up and out is a dislocated DDH, superolateral migration. So normally your femoral epiphysis is beneath the horizontal line and inner to the vertical line. When it goes up and out, is dislocated. So Perkins line is drawn for DDH. A simple question comes. Whereas Helgen-Renner line, again a horizontal line. Acetabular index means a vertical acetabulum, shallow acetabulum. It increases in DDH. Acetabular index increases. When you do an ultrasound, the alpha angle, the beta angle. Remember, alpha angle decreases in DDH. Remember the mnemonic, alpha decreases. It's a very, very important angle. Whereas if you look at the risk factors of DDH, remember, oligohydramnios, risk factor. Metatarsal adductus means medial deviation of the adductus or the forefoot, midfoot, risk factor. Congenital muscular torticollis. When the sternocleidomastoid of one side is shortened, the ear of the same side will come towards the shoulder, chin goes opposite. This is called as congenital muscular torticollis or the wry neck. This is again associated with DDH. Talipes calcaneovalgus means the heel is prominent as compared to CTEV where the heel is less prominent. These are all the risk factors. Family history, breech presentation, female child, firstborn child, and the left side. They're all the risk factors. Remember, twin pregnancy is not a risk factor in DDH. This is metatarsal adductus, medial deviation of the foot, seen in DDH. This is prominent heel, calcaneovalgus. CTEV is very, very controversial. Also remember, DDH is less common in Indians. And people claim because we keep our kids by the side of the body. International authors said, how can you decrease the incidence of a disease after birth? Look at what the literature says. The most common intrauterine position places the left hip of the fetus against the sacrum. This can explain the increased incidence of DDH on the left side. So left is more common. Postnatal mechanisms can play a role. So after delivery, there's a role. An increased incidence of DDH has been reported in cultures that keep the infants with the hip in constant extension. So we keep them flexed, we keep them abducted, it prevents. This is a harness in which you maintain abduction and flexion of the hip. So the head inside the acetabulum, called as Pavlik harness, used in DDH. So at birth, you can use a Pavlik harness, von Rosen splint or backless cast in DDH. So in DDH, 0 to 6 months, close reduction. 6 months to 18 months, because there are a lot of structures inside, open reduction. 18 months, so 3 years, you will correct the femur, take it inside. More than 3 years, you will reconstruct the acetabulum. So when you have to reconstruct DDH, you need to identify where the acetabulum is, you need to take the head there, and if required, you need to reconstruct. Perthes. It is avascular necrosis of the epiphysis of femur. This is the normal epiphysis. This is the condensed, compressed epiphysis. Age group 4 to 8 years. It is more common in males. Perthes is a self-resolving condition. It can be picked up in early stages by MRI, which can be initially normal. You have limitation of abduction plus internal rotation. There will be an axis deviation, and the head will migrate supro and lateral, causing uncovering. In Perthes, there can be a defect in the lateral part of epiphysis and metaphysis. This is called as a Gage sign. In Perthes, at the upper end, you can have a sagging rope, a sclerotic line which can be there, or, as I told you earlier, avian of the upper end femur can have a crescentric lucency. Treatment: maintain the hip abducted. It will get okay. Compared to it, a painful condition. Perthes is relatively painless. Slipped capital femoral epiphysis, age group 11 to 20, associated with hormonal imbalance like hypothyroidism, growth abnormalities. Classical is a painful axis deviation. MRI is investigation of choice. Flexion is limited. If this is the metaphysis, this is the epiphysis. The name says slipped capital femoral epiphysis. Wrong. It is the metaphysis that moves. The epiphysis is stationary. So it's a misnomer. The epiphysis does not slip. The metaphysis moves. If I draw a line over the neck, it cuts a part of the epiphysis. This line is Klein's line. This sign is Strithoven sign. In SCFE, there is nothing above the line. So it's already moved with relation to metaphysis. Treatment: fixation. If you classically look at this child and you have a spot diagnosis, there appears to be thickened calf. They are called as pseudo-hypertrophy of the calf. This is seen in a condition in which your proximal muscles are weak and you have to take support of your body to climb up, called as Gaver's sign.